Welcome to the very first video that I have put on my new YouTube channel. I'm hoping that you can use this video to get something out of it to describe the oxyhemoglobin dissociation curve, that maybe you'll come out of this with a little better understanding. Bear with me. I'm still learning about this process as well, and I'm hoping that you guys can take some of this and if you have any feedback on what could make these things better, on what could make you understand things a little better, please, by all means, feel free to leave a comment and let me know. Uh, this is something that I'm really passionate about. I've been an EMS educator for almost 20 years, and I feel like that when it comes to some of these things, that either we're getting some lackluster education or we're getting none at all. So hopefully this video will give you a little bit more knowledge and maybe you can get something out of it. So I guess we'll go ahead and get started. So, first of all, guys, no doubt you remember hearing about this. I know you've heard about it in nursing school. I know you've heard about it in paramedic school. It's discussed in just about every nursing textbook. It's discussed in paramedic textbooks. It's discussed in critical care textbooks. It's pretty difficult to grasp at times. It goes along with acid-base balance. I remember in paramedic school we were told that, one day you'll just wake up and it'll click. Truthfully, that is the way that it worked for me. I woke up one morning and it just clicked. I don't know why. I don't know, other than the fact that I probably spent the last 6 months with my nose in a book trying to figure it out, which probably had a lot to do with it, but it just clicked one morning. So this may be part of that as well. But to understand it, you're going to have to think about the oxygen process occurring in the body. Staying alive really hinges on having enough oxygen moving to the lungs, to the body, and then all of this to occur, the lungs, blood, and the environment within the body must be functioning as well. You need to be able to get enough oxygen first. You need to be able to be perfused, and you need to be ventilated optimally. Oxygen must be transported via the blood to the tissues. There's no other way. Now, granted, I know that you've read books and it says, well, 2 to 3% of the oxygen going to the tissues dissolves in the plasma. I'll agree, it does. But the remainder travels in the plasma by attaching to the hemoglobin molecules. The most important factor in the amount of oxygen that really attaches to the hemoglobin molecules is the partial pressure of the arterial oxygen. The higher the pressure, the more readily oxygen really just attaches to the hemoglobin in the red blood cells. This is called oxyhemoglobin. Now, without getting too far into the weeds, I kind of wanted to give you an idea of what hemoglobin's made out of to kind of help you with this as well. Hemoglobin's made of 4 strands of amino acids. If oxygen is linked fully to all 4 strands, hemoglobin is 100% saturated with oxygen. Transport of this sufficient oxygen to the tissues depends on an adequate number of hemoglobin molecules as well as sufficient blood volume and circulation. So basically what I'm telling you now is you need to have enough oxygenation. It needs to be able to attach to the hemoglobin. But you also need to have adequate cardiac output, and you also need to have an adequate blood pressure. Now, with that being said, once the oxygen is being transported to the tissues via the hemoglobin, the body's environment determines how much or how little is needed and unloads it from the hemoglobin for use. The oxygen dissociation is determined by tissue demand for the oxygen. And basically, this is where the oxyhemoglobin dissociation curve comes into play. And you'll notice up here, you'll look at the cursor, it's following the blue line. The blue line is the middle. This is what would we call norms. This would be straight line down the middle. and you're looking at the curve and you're seeing different things, what is normal temperature? Normal temperature is 98.6. 98.6 Fahrenheit. Now, with that being said, 98.6 Fahrenheit, then we got pH, 735 745. Well, we're going to look at pH as being 7.4 as being that. So, we get that, and I want you to think about this because this never will stay in the middle. We're always going to either fluctuate to the left or we're always going to fluctuate to the right. So, like I said earlier, talking about oxygen being transported and then binding with a hemoglobin, calling it oxyhemoglobin. When oxygen is loaded into the blood, uh, the oxygen tension is about 100 millimeters mercury as a result of alveolar ventilation. Oxygen is unloaded in the blood in the peripheral tissues where the oxygen tension is roughly about 40 millimeters of mercury as a result of peripheral tissue oxygen consumption. So you'll see there's a slight difference on the amount of oxygen in different areas of the body. Hence the reason why you'll see the curve do kind of like, they call it a sigmoid shape, but I'll just call it an S shape, and it makes it a curve instead of being a straight line. Now, we'll kind of go into this just a little bit as well. The Bohr effect, and there's another effect called the Haldane effect, and we're going to kind of do a contrast and compare with those in just a second. But this comes in effect as well because I want you to know these because it's going to help you realize if the body's making a left shift or a right shift. So the Bohr effect allows for enhanced unloading of oxygen in metabolically active peripheral tissues, something like maybe skeletal muscle. Increased skeletal muscle activity, like I say, when you're exercising, results in localized increases in the partial pressure of carbon dioxide, which in turn reduces the local blood pH. Now, to think about it like this, when we talk about increased partial pressure, we're just going to say the amount increases to simplify things. I kind of like to think things in a more simple way. I think it makes it easier to understand. So if there's an increase in partial pressure, you're going to have an increase of that substance. For say, increase in partial pressure of carbon dioxide, you're just going to have an increase in carbon dioxide. So basically, what is the Bohr effect? I'm going to read it directly off the slide, but the decrease in the oxygen affinity of hemoglobin in response to the decreased blood pH resulting from increased carbon dioxide concentration in the blood. Well, let's do this. Let's give that same example that I used earlier when you're talking about the Bohr effect for exercise. So let's say you're in the gym, you get in there, and you sometimes feel that burning sensation in your muscles and your tissues. That's because you're increasing your metabolic rate and the need for O2 as well. This causes a buildup of CO2 and a buildup of lactic acid. Now, the burning sensation indicates that there's a lack of oxygen to the tissues, and as the pH becomes more acidic, the hemoglobin's affinity for O2 decreases and the curve shifts to the right. And that means more oxygen will be delivered to the tissues. Hence, vice versa. If you're more sedentary, the curve will shift to the left. Shifting to the left means that your pH will probably go up, your CO2 will go down, your temperature is either going to go down or stay normal, and you're going to have a lower level of 2,3-DPG, which we'll get to 2,3-DPG in a second as well. Now, the Haldane effect, that's just a little bit different. The Haldane effect is basically the oxygenation of blood in the lungs displaces carbon dioxide from hemoglobin, which increases the removal of carbon dioxide. Basically, all this is that oxygen is going to take the place. It displaces it. Now, remember, um, when it displaces, there's no more room. The lower the PO2 of blood, the more room for CO2, and vice versa. The higher the pressure of oxygen in the blood, the less room for CO2. So basically, this is the ability of the blood to carry CO2 away or deliver oxygen. So those are basically the two things that I wanted you to know roughly about the Bohr effect and the Haldane effect. It kind of gives you a little bit more insight into what it does and how the oxyhemoglobin dissociation curve works. Now, when we're talking about this, some of the easier ways to remember this is the Haldane effect describes how oxygen concentrations determine hemoglobin's affinity for carbon dioxide. And the Bohr effect, on the other hand, describes how carbon dioxide and hydrogen affect hemoglobin's affinity for oxygen. So, you know, one thing that I will tell you this is when you start to research about the Haldane and the Bohr effect, remember that one deals with the affinity for oxygen and one deals with the affinity for carbon dioxide. Now we're going to go to the last one, and then we'll talk a little bit about shifts and see if we can tie all of this together. 2,3-DPG. All right, 2,3-DPG. You remember earlier when I was talking about the oxyhemoglobin dissociation curve and how oxygen was transported to the tissues and oxygen was offloaded and carbon dioxide was picked up. With the oxygen being offloaded and the carbon dioxide being picked up, let's say, for example, you're looking for more oxygen. Well, if you think about it in terms of a little red truck, you have a bigger key. The bigger the key you have, the more oxygen you have. The smaller the key you have, the less oxygen you have. Or you can think about it as a crowbar as well. The bigger the crowbar, the more oxygen. The lower or the smaller crowbar you have, the less oxygen you get. So basically, when hypoxia is encountered in your outer peripheral tissues, the concentration of 2,3-DPG can accumulate to significant levels within hours. At these concentrations, 2,3-DPG can bind to the hemoglobin and reduce its affinity for oxygen, resulting in a rightward shift of the oxyhemoglobin dissociation curve. This results in enhanced unloading of oxygen by hemoglobin and results in enhanced oxygen transports to the tissues encountering long-term hypoxia. So if a patient had been there for a while, larger amounts of 2,3-DPG or the crowbar or the key, however you want to describe it and remember it, will be there to pry that oxygen off or to give a bigger key so that you can get a larger amount of oxygen to those tissues. Now, we'll go right here, and this is probably the thing that you've been waiting for. You're probably wondering, well, if I know about the oxyhemoglobin dissociation curve, what is going on with my patient? How do I determine what am I looking for, and why? Well, I think this slide will probably answer your questions. I understand that when we're looking at the oxyhemoglobin dissociation curve, we're looking at the partial pressure of oxygen and we're looking at oxygen saturation of hemoglobin. Typically, we're not able to get those numbers unless we have an ABG or some labs. But you can always look at your saturations via pulse oximetry. Remember, using pulse oximetry, that's one thing about it is very low levels of SpO2 can result in serious symptoms or things going on. But with that, the thing I want you guys to remember is too is sometimes it can be very latent. Sometimes it can be 2 to 3 minutes behind, maybe even larger than that. If you have just 3 red blood cells that are fully saturated pass through that sensor, then you're still going to read 100%. So don't rely on it completely. You still need to be using end-tidal CO2. You still need to be considering your pH and different assessment clues as well. So if we're looking up here at the oxyhemoglobin dissociation curve, and we have a patient who is in acute acidosis, they have a high CO2 because they're withholding CO2. They have an increased temperature. That means that they'll have elevated levels of 2,3-DPG. When you have all of that, you're going to have a rightward shift, because what does the patient need? The patient needs more oxygen. Now, when the curve shifts to the left, this is going to have an increased affinity for oxygen. Your crowbar and your key obviously are going to become smaller because it's going to have an increased affinity for oxygen, and it's not going to pry it off. And those things can happen, such as decreased levels of PCO2, which is decreased levels of CO2. So if your CO2 goes down, your pH goes up, right? Well, if your CO2 goes down and your pH goes up, that means you're going to have acute alkalosis, resulting in decreased levels of CO2, telling you that you don't need to breathe as much because you have the oxygen there, right? And then you have a smaller crowbar, or the smaller key of low 2,3-DPG. Now, I hope that you guys got something out of this, because there's a variety of environmental factors that can really shift the OHDC. Man, that sounds a whole lot easier to say than the oxyhemoglobin dissociation curve. But think about the patient's metabolism, their pH, CO2, the temperature, whether it's going to shift to the left or to the right. Now, I understand that there are people that can look at this and they can say, well, the patient's obviously suffering from a right shift of the oxyhemoglobin dissociation curve. Well, first of all, you have to know what you're looking for to know if the patient's experiencing a right shift. So, with that being said, I'm hoping that this can kind of give you just a little more insight about this, and I'm hoping that it can give you a greater understanding. And maybe next time this video will be a little better. Like I said, guys, please bear with me. This is a new YouTube channel. I'm really trying to get something going online so that we can at least have some type of education if we can't find it. So if you guys don't mind, please click the subscribe button. I'm going to try to add a video at least every week or two to try to build these things up. And if you got any questions, comments, or concerns, please leave me a comment. Thanks, guys. Y'all have a great day. See y'all.